All right, I think we are live. I also take little responsibility if we're not, but either way, this will be recorded and I'm super excited. So this series is called Heartstorming Healthcare for a very clear reason. I hope it's kind of clear. Oftentimes we do brainstorming and we talk about brainstorming, and I really want to get out of our heads and into our hearts. And so that means I have intentionally curated the most heart-centered people to have this conversation. And as I was making the list for all of the titles that I wanted to cover, Olivia Morris ended up literally on all of them. So I'm like, you know what, Olivia, I think you're just supposed to be my co-host. And Olivia's like, sign me up. What dates? So, and those are the kind of heart-centered people that exist in the world and that I'm happy to bring here. So my name's Claudia Cometa. For those of you who don't know, I'm surrounded by these amazing people who we will be talking to today. And Olivia will be helping me just think of amazing things to say. And also, as soon as she starts talking, for those of you who don't know, I just love her accent. So I could sit back and listen to her all day. It doesn't even matter what it is, even though I know it'll be good. I could listen to her accent all day long. So I'm thrilled to be with you all. Thank you all for being here.
Thank you for having us.
Yeah. So excited. All right, let's start with introduction. So Olivia, I guess, you're the co-host. Let's start with you and then we'll go around the circle.
Perfect. I guess for me, for anyone who doesn't know me, predominantly I'm a physician advocate. I have been for a decade and set up Doctors Living. I'm basically here in Ireland and I help people in the UK and the States and Canada really just kind of help with their systems and burnout and stuff. And as a result, I ended up setting up Verity Barrington, which is kind of an ethical healthcare consulting company and just put really wholesome people together. So long story short, I basically help doctors in both sides of the field, really inside and outside of clinical practice.
Amazing. And we're actually, the next session is going to be physician experience because the experience of the entirety of the system needs some help. So we will be on to that next. Brad, do you want to go ahead and go next? And then Dana will be up next.
Sure. Brad Schwartz. I'm here in Chicago. I'm a lawyer. I am the president and founder of Greater National Advocates. I'm a medical error survivor, and my whole mission is dedicated to making sure that patients and families who are struggling within the healthcare system can get immediate access to the good people who can help. So we don't charge anything to get listed on the platform because the whole idea is to get as many advocates out there available and doing this good work. So thanks.
Yes, so excited to have you. All right, Dana.
Hi, thank you for having me. My name is Dana Dayton. I live in Alexandria, Virginia, outside of the Washington, D.C. area. And like most of us here, we have either gone through our own personal medical crisis or helped a loved one that has. And for me, it was stage 4 esophageal cancer about 10 years ago as a young woman. And I was told there was no one else like me. But of course, we all know that's not true. The result of that, though, was, I was really given kind of a premature death sentence. And I had to do all of my own research and advocacy to find just the smallest little resources that would help me ask the right questions and advance the conversation. And I was very lucky and that was successful. But most people, may not know how to find those resources or not have, the health to do so or the family members to help them. So they reach out to me and I try to do what I can just to, help them stay in control of the dialogue and hopefully get to the next day.
Yes. You both are just prime examples of what terrible things can happen, but what good can come out of it. And so that's really kind of where I want to go with this is let's really dive into and identify where some of the challenges and obstacles are, but ultimately not end the day on a negative Nancy note and like there's no hope, because I think we're all here because we believe that there is. And so I'm going to kick off the first question and then I want to hear Olivia talk and ask, because her voice is so much better. Her accent's so much better than mine. I don't have an accent, obviously. So what I would like to start off with is, and who whoever wants to take this one first, is what is your take on patient experience versus patient satisfaction? So I know on the physician provider end, it gets really exhausting trying to satisfy patients' expectations because they are all across the board, sometimes reasonable, sometimes unreasonable. But I find that there is, although some overlap, a distinct difference between patient satisfaction and patient experience. And so you both have had extreme experiences in the healthcare system. And so I just would love your take on that topic.
Well, I'll start and say that, these are words and catchphrases that seem to evolve every few years into something else. I mean, you're asking about patient experience, patient satisfaction, which leads to patient-centered care, and it leads to all these other words. So for me, I mean, I don't know what the difference is. So I'm here to, I'd like to hear, I'd love to talk about this because, I compare it to like patient safety. What is the difference between patient safety and patient advocacy? What are patient advocates advocating for? We're advocating for safe care. At least that's a part of it, not get harmed. So I don't understand why all of these subsets of experience are why they're all isolated, why they're all, we all take and run with our little things, but I think what we're talking is what's the big picture? What does it even mean? So, I mean, these are survey based things that we're talking about. Right? You fill out a patient experience form, and I don't know. So I'd like to hear what somebody has to say about that.
And I think the surveys are a great point. We'll dive into that. Dana, do you want to share any insights on that?
Yeah, I agree. It's, the word advocacy is a little bit nebulous. And when you're just entering a medical crisis, I'm not even sure people recognize what it is. People are told you have to advocate for yourself, but it can mean so many different things. It can mean safety. It can mean just asking questions. It can mean getting, support outside of the clinic. So I think helping people understand what advocacy really is and what the power of it can do is important.
Olivia, what you got? I would love to know what questions you have or insights on that topic.
Well, actually, I was just thinking as you were talking about it and hearing the word patient advocacy, because obviously I sit in the physician advocacy, but yet my network is filled with so many people talking about patients and their struggles and what they're going through. And I think I've always wondered when you look at healthcare and you say, well, patients need so much advocacy to help them and help them through the system. But then on the other side, you've got physicians and they need advocacy because they're struggling. And you sit there and go, is there something that can bring the two together here, that can maybe bring both sides and say, well, if both sides need advocacy, obviously there's a bigger problem here because you both need it. You both see that there's an issue. So how do we get the two to line up a bit better and say, well, can we get some communication between the two? And I'm just wondering for these two here, just do you see that there being some kind of gap where we can try and bring the two sides together from your own perspectives and experiences?
Well, from my perspective, I think we're well on the way, because I think when you are advocating for a patient, you are relieving a lot of burden and stress from the clinical team. So I think that's the way it needs to evolve. I'm all for physicians, having advocates and so forth, but they're not in the room with the patient during an appointment advocating for the physician. We need the physicians and the clinicians to understand that when there's an advocate in the room, they're working on behalf of the patient, but in the process, they're making your life a lot easier.
I agree. And also, many of us are blessed to have incredible physician teams or provider teams. But as good as they are, many of them have not truly walked the walk. And an advocate that really does have, inside knowledge outside of the medicine or the therapies. There's so much more that goes on. There are side effects and insurance issues and, so care issues, so many things.
And just to come in there, because actually it also includes you, Claudia, as well, which is if you was to sit there and talk to a physician now about how they can help the patient experience, if you could talk to them specifically, what would you be asking them to do, knowing their already current restrictions and difficulties at the moment? What would you like to be able to sit there and say, well, this is what we're actually asking for?
I think this is a fantastic question because I visualize, I'm always like into analogies, and I visualize, two friends meeting at a coffee shop, and, both of them have their individual struggles. And it's like one friend is meeting with the other to get some help, to get some, advice on where to move forward. And the other one's like, I'm like in my own thing, like I can only give so much. And so I think these relationship dynamics play out in various areas of our lives, and medicine happens to be one very significant one, because this is obviously, can be very life altering. So, and I think this is a fantastic question, is what exactly do we want the patient experience to look like, and what do we need from the physician that we're not getting? And I would say, from the 7 years of working with the clients that I've been working with, and my own experience with my dad, is first and foremost is clear, open, safe communication. So I think a lot of people immediately feel dismissed, immediately feel talked at and not with. And what I think is some of that core issue, and I've talked about this on a few other podcasts, is physicians are trained, like it's almost like the humanistic communication is trained out of them, because they are trained in a certain way to speak to their attending physicians, to their superiors when they're going through training. And the way that they're taught to speak to them is very truncated, very high yield, concise, like tell me only what I need to know. And they are also talked down to by their superiors. And so they've got this like communication style that they've been trained to have. And now they go into the patient room, and the patient's expecting, a knowledgeable family member to talk, a knowledgeable, compassionate soul. And so how do we bring these two worlds, how does that work? And so I think some of this, kind of has to back up all the way to training and the toxic culture that physicians are trained under. And I don't think that anybody is going into these exam rooms saying, how could I be the most demeaning and dismissive to my patient? I don't think that's a desire for anybody, but it is what's felt on the patient end. So I'll shut up and let the others talk.
I think sometimes the time, the limited time that physicians have is probably the most threatening to both parties. So they don't really have time to let anything else in the room. They need to say what they're going to say. They need to get the orders written. They need to get it to somewhere else. And I think that they could feel a little threatened if an advocate is in there saying, hey, how about this? Or can we talk about these, additional ideas? It's going to get them off their game, and they're not going to be able to make it to the next clinic room that they need to get to. And I just think that, if we could retrain them to understand that there is a benefit in having this extra voice that can really be helpful, in the long run, it might be better.
I just want to just jump in there, just before obviously somebody else takes it there. Just something very important that you said about the time part. I had a very big conversation with a few CEOs of hospitals over the past few years. And obviously with the kind of coming of times with things like AI and all that, I asked a very big question to a lot of them. And one of them came back with the best, most honest answer possible. When I said, look, should we sit there and say, look, we're going to take all this excess administration away from physicians, etc. We're going to try and do that. Does that mean our physicians will then be given more time with patients? Because both sides are sitting there saying that that's really what's required. Both sides say it. Will you allow them that? So if we can take all this horrible stuff away and give them the time, are you going to do that? Or are you going to make them push through more patients? And he said, honestly, I could say with both sides, the personal side of me says, absolutely, I'm going to give them more time. the professional side of me says, I can't. You know, my head's then on the chopping block, because if I do that and I give them more time, but there was capacity to put more people through, you know, get rid of the waiting times and do all that, I get sacked. Somebody else comes in who cares even less, and it's still going to be the same. So you sit there and go, well, what do we do in that regard when we sit there and go, it's not our physicians saying we can't give more time or we don't want to, but it's more their superiors saying, you can't have more time. Come on, move quicker. You're not getting 15 minutes now. Now we're giving you 10. And you don't even have a break to do your paperwork now. We're pushing you on to the next patient. There's another patient waiting. So that 15 minutes you spent on one patient where they only had 10, well, now that next patient only gets 5 before it's the physician's fault. They spent too long on the previous one. What do we do in that scenario to sit there and go, well, how can we change that system? Because that system is far bigger than the people who really care about people and patients and patient experience and satisfaction. And to be honest, and in the broader scheme, their health, their outcomes. You know, for me, that personally supersedes even their experience. It's, well, did they end up with a better health outcome at the end of this? So I'm going to put that once again back out to all three of you. What do we do in that situation?
What you got, Brad?
I'll say, well, number one, you know, as an advocate for the patient, you know, based on the scenario that you described, I would have to say that it's time to move on to a different clinic. Because if the doctors recognize it and can't do anything about it, then what's the point? Now, they know about the problem, which is why I think that I have a lot of confidence that, you know, within the next decade or so, this thing is really going to turn, because physicians already realize that they can't do it. So what have they done? They've created a completely separate model to help them accommodate for this problem by way of, you know, concierge type medicine, or, you know, that added subscription fee that, you know, allows you access above and beyond what you would be entitled to, you know, through your normal corporate, you know, business. So I think they get it. Not everybody is capable of implementing it, but I think that recognition, I mean, I think we're on our way. I really, really do. I mean, the whole system is going to have to be just blown up and changed. And it's starting a little bit now, hopefully, with you know, medication access and medication prices and transparency and all of these things. While they're like, there's a lot of pushback, and, you know, while we do have price transparency, we know not everybody is following it, but, you know, they will. You know, when more teeth gets added to everything, when the penalties increase, you know, when we start pulling together our collective voices, the mechanism is there. We just need to pull all of these strings to make it work. I think everybody knows what the problem is. That's why I get so frustrated with, you know, patient experience, patient satisfaction, patient-centered care. What all these words, all they are doing is identifying the problem. And then people go and say, oh my God, we got this word. I'm going to go get a grant and I'm going to study this problem. And then they get all their numbers. They come, wow, look at this. And there's more stuff that we all know. And we keep sitting around talking about everything that we already know. That's where advocacy comes in, because advocacy is not based on, you know, doing research. You know, look, this research is the research that is needed is not going to get done anytime soon, because nobody is stepping up to fund the big research, which is what is the difference in an outcome or an experience if somebody has an advocate versus somebody that doesn't have an advocate. This is self-reporting, you know. So we need to like find a mechanism. I'll leave it at that. Those are my frustrations. I don't like words. I don't like these words. The whole reason I started Greater National Advocates, because I know that all these words exist out there, but nobody's doing anything. They look real smart, when they talk, about all these numbers and all these research that they're doing. They're like, oh, thank you. Round of applause, and we'll go get some more money and do this again next year. We'll see you at the next conference. So good luck, patients. See you later. So
Do you know, I totally love that, because do you know what, when he says that, I see that in every different corner of healthcare, actually. That, like, there isn't a corner that hasn't literally had that kind of energy, and we'll come back to this next year. And you're like, oh, not this again.
Circle back. Everybody's circling back.
yeah.
Yeah.
I want to jump in, okay? Because I think that Dana's experience might be something we could focus in on here as an example, because we've never met before, but we do have something in common that I found out from you based on your experience, okay? About a month before I was born, my father's dad passed away. I knew my whole life growing up that he died. I knew I'm actually named after him. I knew he died of cancer, but nobody told me that he was a physician who died of esophageal cancer.
Wow.
So Dana, I'm not sure what your experience was, but this esophageal cancer doesn't just like come out of the blue without any sort of symptoms, does it?
Well, for me, it kind of did. I was
Okay, that's interesting.
very
Okay.
atypical patient. I mean, first of all, it usually strikes men that are older, like 65 and above, who have had, a history of smoking or drinking or poor diet
Or GERD.
or GERD. Exactly. And there are usually symptoms like GERD, Barrett's esophagus, trouble swallowing, things like that. I was asymptomatic. I had none of those, but I did have some other really peculiar things. I presented with lupus-like symptoms, and I was treated for lupus. The more I find out, though, is that autoimmune issues are really often cancer that is just masquerading as something else. But physicians don't really like to talk about that. There's not a lot of evidence. But of course, autoimmune issues are, about inflammation, which is the root of cancer. So I do think there is a bigger connection there. And if I had, the brain power and the money to do a big study on who presented with, lupus or some sort of other autoimmune issue before they actually had a cancer diagnosis, I think we might be onto something. It's not going to be, foolproof, but I think there is a pattern or a trend there because I've talked to so many people. So I really was on a very long diagnostic journey because nobody suspected esophageal cancer. My mom had actually passed away from stage 4 colon cancer when I was about 31. And it was a very ugly, quick, situation. She died within 6 weeks of her diagnosis because she went septic. And it was so tragic and so ugly. You never forget those sights and smells and things like that. I promised myself I wasn't going to follow in her footsteps. So I got a colonoscopy right away at like the age of 31 or 32, had another one at 36, had another one at 40. Those were clean. It was very hard to get them because, all I had was the history. I didn't have any polyps or anything like that, but I kept forcing, my team to make sure that I was okay. I had 3 young kids. And then just after my 3rd colonoscopy, I started to not feel well. And that's when the lupus appeared. I had like this knife grinding pain in my joints and the malar rash, the whole 9 yards. I was actually treated for lupus, had some resolution of the symptoms, and went about my daily life. I was working full time, taking care of 3 kids. And then all of a sudden things got worse again. And I had just a very vague abdominal discomfort. It wasn't pain, but it was like this never ending ache. It prevented me from sitting up straight or from standing very long. It just was very hard to deal with. And It took me a long time to get any attention. I was told I had, irritable bowel syndrome, and, that wasn't the case. I knew it wasn't. Long story short, finally had a node in my neck that popped out. And that's what got everybody focused on, a malignancy. But it was really hard because it had very frayed um, markers, and it did not point to esophageal. It didn't point to anything. So people just guessed it must be ovarian, it must be breast, it must be lung, it must be brain. Maybe it's a cancer of an undiagnosed primary. Nobody guessed about esophageal until finally the very last test I had after a whole barrage of different tests was another colonoscopy, but this time with an endoscopy. And everybody was shocked. And that's what it was. It was stage 4 because it had already metastasized. The feeling that I had in my abdomen was basically peritoneal metastases that were kind of wrapping around my intestines. And from there, everybody just said, I'm so sorry. It's not your fault. They knew I didn't smoke or drink. And I felt like that was just the worst thing to say. I'm like, I wasn't raped or anything. Like, of course, it's not my fault. And you shouldn't even say that to somebody that was. But they said, just get your affairs in order and enjoy your kids, and we'll find, some good palliative care for you. And I just said, this can't be my path because I'm healthy otherwise. And I'm not one of, these like 70-year-old kind of men who has had bad habits. So there must be a way out of this. There must be something we're not looking at. I don't fit in that data bucket. So stop assigning me to the prognosis that they have. And I went to several academic institutions until I finally found one where somebody was actually willing to spend that extra time, learn a little bit more about me, and look outside of, the box, and also was able to think creatively about possible therapies that might work for me, that because I was just different. And I spent a long time doing my own research and asking questions, and really that helped me maintain a voice in my treatment. And I would come with my little notebook, and everybody would say, "Oh my God, what's she going to ask today?" But I do believe that that is what saved my life, in combination with people that did spend the extra time and that did look under the rocks, that were, a little bit different, because guidelines are there for a reason, but guidelines don't cover everybody. But I do think, going back to the original point of this, our system is set up to de-incentivize physicians to spend that extra time and to do things that are a little bit off course. That's just not how our system works. I love your optimism that the whole thing's going to get blown up. I wish I could share it as enthusiastically. I want it, but I don't know if I can taste it yet. I think things in this country just work kind of against that, especially with the profit centers that, everybody needs to meet.
Well, you are in, you say Arlington?
Alexandria.
Alexandria. Well, we're marching in DC in September for legislation, patient rights, patient safety, all kinds of stuff. It hasn't necessarily been announced yet, but within a few days or so, I'm going to be flooding you with info about how
Please
we
do. I'll be happy to join you.
Hi.
Can I get a picture of you two marching? I need to, that would be so, you didn't even know each other till now. And it's
No,
really
we're gonna-
insane, the parallels that, I mean, I guess this is just the way the universe works. So I love it.
So yeah, I mean, I'm just gonna say, Dana, from where I see it, my optimism, I could be a real negative person. Believe me, I get pissed off all the time. But I turn the energy. Every day it's something else. You just gotta keep going and keep going.
I agree.
And making as much noise as you can. And like we said earlier about all the different nomenclature and subsects and so forth. I mean, I'm not marching with a bunch of patient advocates in DC. I'm going to get them there. But right now, I'm partnering with these patient safety people who didn't know about patient advocates. And, what the hell is the difference? It drives me crazy. We're all working for the same thing. We all got to fight for the same thing.
I agree. I agree. Do you all think that the role of like reimbursable navigators is sort of what our system is throwing at this, and does it help?
Are you talking about like, Medicare, Medicaid?
Well, now there are professional navigators that some insurance will reimburse as part of like your care plan.
Right, but see, that's another nomenclature problem, okay? Because they're calling them a navigator, and then it becomes up to us to then convince this carrier that, well, I'm an advocate, but I'm a navigator. You should pay me to do this job because my job description is the same thing that you're authorized to pay, but my title doesn't match with the code that you're going to need to approve my payment. So, that is a problem. I would say that I also think that it's a problem if an insurance company has control over the advocate, monetary control over the advocate. We do not want the advocate ever to be beholden to
That's
the
true.
payer, because that creates even if it isn't a conflict, it could certainly create the appearance of a conflict. And I mean, I think it is a conflict. There's no doubt about it. I mean, they're going to rein you in a minute. I've always said I cannot see Blue Cross or Humana paying for an advocate that is going to take that money and then go back and fight against Blue Cross or Humana.
Right.
That doesn't make sense.
But I mean, to me,
So-
to be honest, that's all advocates. I mean, I sit in the physician advocate bit, and I've had people say to me, well, if you're not going to get paid for it and to help these people, well, will you set up as a charity? And I said, no, because the only way to be a very authentic advocate is to absolutely stand on your own in a way. And yeah, you can collaborate with other advocates. But as soon as you tie yourself to an organization or a company or to somebody else's expectations, automatically there's this shield around you where there's perception. Whereas I always said, well, I'd rather be smaller and have my own voice, but people know I'm absolutely independent. And when I say this is wrong and I have to kick down a door, I will do it. But I'm doing it for the people that I'm standing for. And I would say, I'm not a patient advocate per se. I would say the same is probably for you, which is as soon as you tie yourself to somebody or an organization, suddenly there's a perception that there's something that could potentially holds you back even.
Yeah. I mean, we're working with the self-pay model right now, but there are other things that are, coming into play as well. We need to build awareness of the profession. The numbers are growing. I mean, I'm not going to sit here and say that. I mean, maybe my optimism is just based on what I see in terms of the number of advocates out there and knowing that they're busy and that their phones are ringing, and not ringing once a month or once every, daily
Sure.
we are fielding calls. And that's because, you said earlier, I believe that, people aren't really looking for patient advocate. They don't know what the word is yet. They're not looking, they're not Googling, I need a patient advocate, I need a patient navigator. They're starting to do it with advocates. But what they're doing is they're saying, I need help. Here's what's wrong. Nobody's listening to me. The doctors aren't calling me back. They can't find my chart. How could it be that this doctor, told me to go see a specialist, and then they told me then it gets denied, and now I got to wait another 8 months for something that I'm worried about. I don't know.
I love how fired up you are, Brad. That's why, like, there was no doubt you had to be on this. And all of you. I mean, I think it's a great mix. And I agree with all of the optics of all of these names, and how this, the C-suite talk is not my talk either. I agree. Like, I really don't care much about what the Press Ganey survey results say, because I've never ever filled one out. I don't think any of my clients have ever filled one out. And so I don't really know who's filling them out and how honest they're being. And so, a lot of these optics are relatively meaningless to me too. I don't know, what I would love to see is a focus group of patients being, questioned and asked about, and physicians too. Like, we're going to talk about that, but can we have a conversation rather than, well, look at these scores. They're all fives, you know, like, okay, what they probably just wanted it out of their inbox. Like, I don't know that anybody's really paying attention to these surveys. And to give you two stories on how the optics are happening within organizations, you know, a world-renowned hospital has an office or department of patient experience. And so, you know, you're like, oh, sounds great. Amazing that they're doing this. And, you know, when I actually filed a report with them for one of my clients, they did call and they listened, and I was on the call. They listened to all of her accounting of what happened. The way that they handled this was to take her accounting, go match it against what the chart said, and then come back to her with a letter, not even a phone call, a letter that said, well, it didn't match. So what you said must have not have happened. And so we're closing the case. Like, that's the office of patient experience. Like, what planet are we on? And then just for market research, because I like to have fun with this stuff, I recently saw a posting for a director of patient advocacy by Pfizer. And I have no problem saying that. I'm like, I'm going to apply for the fun of it, just to see, just to see if they would think somebody who has been literally like a founder of a patient advocacy company would be a good fit for this. And this is it says that the role is to ensure that the voice of the patient is at the center of our work. Like, I feel like a quick view of my LinkedIn would be like a good fit for that, right? Or at least get me to the like interview, right? Because I just want to like, I have really no intention of working for big pharma, but this was just market research. This morning at 3 a.m. immediately, like maybe less than 24 hours after I applied, you're not a good fit. I'm like, yeah, probably because my bio says I expose the deficiencies in healthcare, and they're terrified. But this is the point. Like, who is getting that job? Like, who is getting that job and making this department look fantastic, just like at the hospital? Like, these departments look great. Look, we have a department of patient
It's somebody who already works in pharma, who has pharma's best intentions, is the simple thing, and who can just use a different voice and say the word patient. And that's it. Like, it's simply that, because it's box ticking. But that happens in healthcare too. It's like, oh, well, we've got these wellness initiatives for all of our clinicians, and we're going to put pizza in, and look, we're doing these things. And you're like, just stop with the nonsense, okay? Just scrap it. Look, Pfizer, you're not interested in patient experience. Just stop with the title. We all know it's absolute crap. And let's stop with the pizza parties for nurses to keep them going on their 25th hour. Can we stop that? Okay, that's nonsense. But I think we need to sit there and go, the correct people aren't the ones getting the jobs, the ones that could really make a difference, because they don't make profits. It's the same as in the States. It's like, why can't doctors own hospitals? Why? Because they'll put patients first before profits. That's why, because they will do the right thing. But that's not the ending. That's not what they want. It's not what governments want. It's not the people who are paying the government what they want. You have to follow the money trail and go, well, the money trail says this has to be profit first. People are profit now. And I know it has been for a long time, but actually it's only becoming bigger. You look year on year, healthcare is costing more. So you sit there and go, when does it stop? When you're suddenly making families more bankrupt, when there's a bigger divide between rich and poor, and you say, well, the poorest people now can't access it. Why? Because doctors now have private practices where they can offer more time to patients, but now you can't afford it. There is going to be more divides. And you sit there and go, well, I don't foresee an ending that ends very well, other than people that are now jumping on the bandwagon and saying, well, we'll bring in AI because it reduces costs. Yeah, well, it also reduces humanity, also reduces face-to-face consultations with a doctor who sits there and goes, look, I've got you, I'm actually listening to you, which sometimes you absolutely require. One of the examples I had recently was, well, what do you do in a situation in front of AI where, for example, it's a horrible example, but there's a woman sitting in front of you, her husband's next to her, and for some reason, just something doesn't feel quite right. And then for a minute, a doctor who just has this kind of human instinct says, can I talk to you alone for a moment? They just have this thing. There's no words. There's nothing that said anything. Can I just have a moment alone with you? Or we'll just go and get you changed? And they speak and they say, sorry, my husband's abusing me. I couldn't talk in front of him. I couldn't say anything. AI, robotics, or anybody else cannot do that. But yet that is where we sit there and go, well, that's an element of patient safety right there. And that's something that can't be replicated because that's a human interaction. It's human sitting there going, something just doesn't feel quite right. Let me just check something else. And it's that bit you can't get away from. But how do we sit there and go, let's bring in tech, let's bring in AI, it reduces costs. You go, that's not the solution here. It never was. Tech
Right.
and the barriers aren't. But covering your ass, sitting there going, well, actually, our physicians shouldn't have to go through 10 hours of paperwork to cover their ass that they're not sued. That's ridiculous. They shouldn't have to jump through hoops to do the paperwork for insurance to make sure that everyone's covered and paid. You go, well, reduce the crap and get rid of it. Don't change it. Just get rid of it and sit there and go, well, no, we're not. We absolutely refuse to do this chain reaction of patients. Patient outcome must come first. Right. Well, then, if our doctors who are experts in this, and our nurse, our clinicians, and our patients are both saying we need time, and I know when you were saying, Dana, earlier about actually, talking to your physician and actually finally getting to what was really wrong, sit there and go, well, if that was the case for everyone at the beginning, do we not prevent this massively long, terrible road of going, well, actually, if a doctor just had time in the beginning and said, look, what's really going on? Can I look at this and let me have time to just think about this for a minute without rushing and running around? Would we actually get better outcomes and actually prevent these terrible tragedies, which do end in really bad outcomes sometimes? This may not have ended as lucky as it did for you. But actually, just as it happened, you did have a doctor that listened, heard something, and said, well, let's do something here.
Absolutely. I mean, I think that's where the art of medicine comes in. Art can be based on, a scientific background, but you have to apply the art, and that's the humanity of medicine. And that's what gets lost, in our system where we've built so many layers of insurance and, culpability and things like that, that there's no room left for the human touch, the personal connection at all. And that's why things get lost. And, on top of that, our system is not set up to honor preventative or predictive medicine. It's only set up to deal with acute situations. And by that time, you're lucky if you can figure out a good outcome. It makes it much harder when you're starting, miles down the road than if you could have had really high quality care before you even present it with something. But that's part of the reason I'm a little less optimistic about being able to fix everything. And I'm an optimistic person by nature, but this just seems so heavy and so much. And I do want to just say, to play a little bit of devil's advocate, I won't mention the institution, but I'm the co-chair of a patient family advisory council at a comprehensive cancer center. And they really do have their ear to the ground as far as the hospital administration goes. And they really do listen to the patients and the providers that are on the committee. And the Press Ganey scores are looked at and reviewed. And I really honor the work that they do to try to mitigate issues that have come up so that they don't happen again. I know that's not everywhere. This particular institution has a big campaign, for zero harm, as they call it. And I think that that's really innovative. And I hope that others, will follow. I think at the end of the day, that's going to drive business their way when they have other patients that are able to tell their successful stories. And it will benefit that institution. It might take longer to get there, but that's, really where the rubber meets the road. Unfortunately, the checks and balances that we have in place, though, as we've been talking, with insurance and things like that, it's almost hard to see our way through to doing the right thing because we're just always trying to cover, something. So,
Brad, I know you were fired up about AI. What are your thoughts on AI?
I went last year to the largest, most well-known healthcare technology, touring conference. And I sat on the patient experience panel, which was a pre-conference panel. It wasn't part of the real show, but beforehand they got me and people like Dana up there, and we talked about all of this stuff from the patient experience standpoint and what's needed. And we're talking about that human connection. And then I said, well, I'm here, I don't like these big old tech things or whatever. I decided I'm going to go walk around and check it out. I checked it out, and I was blown away. The entire pretty much theme of the whole event was, how can we use AI to get the patients off our back, keep them satisfied, so that we don't have to deal with it, and pretty much use AI to like trick the patients into thinking that they're having a patient experience. And I left. So those are my thoughts on AI in terms of patient experience. Now that doesn't mean that from a purely diagnostic standpoint, and if you use it the right way, fine. But to just say, here, these patients won't be bothering you anymore, we're going to have AI answer all their questions. That's how they're trying to sell this to the practice groups. And so
I've seen these stories. I remember when the whole AI thing blew up, and one of the first things I saw, obviously because of my network, it was like AI versus physicians. It was like, oh, well, they're better than doctors. Recently I saw it was AI versus nurses, and you're like, oh, when is this going to end? And you're like, I see where they're going with this. They're like, well, actually what we can do is automate these things for patients. It's better for patients because then they don't have to wait, and they get the telehealth, and they get all these things, and it's all just really cool, and they get the diagnostics easier and all these things, and medication, and oh, we reduce errors because doctors aren't involved anymore. And you go, will you just stop this? Because this is lunacy. But then the FOMO comes in. And I see it at the moment, because obviously I work with startups as well, where it's like, well, if you don't have AI, we're not going to invest because you're not part of the future now. And you're like, this is really insane now. And then people go, oh, well, our company is now powered by AI. And you're like, no, you're not. You're an algorithm, but you said AI because you need the investment. And now you're putting AI into healthcare because that's the only thing investors are interested in when it comes to healthcare now. Can we stop? And can we all just take a breath for a minute and say, actually, what patients need, what clinicians need are each other to communicate together and get better results together? That's all they needed, because the only thing that really stops better outcomes is the nonsense and the paperwork and the interference from people who are not in that situation. It's the people that are not in the front line or in that room with their patient and their clinicians. It's everybody else who influences it. It's everyone else actually causes the bad outcomes, the insurance companies, the C-suite, the governments, all these things. And you go, well, now you stick AI in, and you go, well, now how do you argue? Because those in charge who are not sitting in front of a patient goes, I'll buy it because I get more profits now. I don't need to worry about bringing in more staff. I don't need to worry about excess costs because now we have AI. I argue, well, then who's responsible when AI gets it wrong? Because it will. What about when AI misdiagnoses, misses something, and a patient ends up with a bad outcome? Do we blame the physician because there has to be a doctor's name on it? Or do we sue OpenAI? Do we sue these companies because they're going to say, we never said that we're healthcare experts. We're just a software platform. You can't sue us. And doctors say, well, it can't be us. It's the C-suite that brought this in. It's AI that's diagnosed. It's nothing to do with us. You can't sue us either. And the CEO goes, well, it's obviously not us. It's nothing to do with us. It's the doctors using the software. So you go, who is responsible when that patient has a bad outcome? What happens when you sit there and go, I didn't see anyone. They didn't diagnose my cancer. Oh, there was a glitch on AI that didn't notice that my temperature was too high. And you go, who's responsible then? Because at the minute it's easy to blame a clinician, but what about AI? Can we blame it? Can we blame everyone then when it goes wrong? Because it has to at some point, because nothing is infallible.
I mean, yeah, what's going to happen when relying on AI becomes the standard of care?
Yeah.
I mean,
Well, do you know what? There is no standard of care. AI can't care. So actually what you sit there and say is, from the moment AI's in, you've removed care, because there is no health care. There's no care. It's not even health. It's technology. That's it. So,
Right.
but I mean, if you remove humanity and you remove care from healthcare, well, there's nothing. Might as well just wing it and go back and live in a forest and forage. You may as well, because you've lost everything that's so important to people and what makes us who we are, these interactions. And I always say to people, the majority of us are brought into the world by clinicians. They're also the last people that see us and they pronounce us dead. They're part of every experience in our lives. Our most vulnerable moments, the moments that we're so scared, the people that sit there and say, I'm really sorry, your partner's gone or your parents have died. But yet we sit there in these moments and actually forget both sides of that interaction that make us actually part of who we are today. The moments when we're sick or we're pregnant, or we give birth, or our husbands have been in a car crash, and all these things. That interaction between the patient and the clinician is so powerful. But yet we sit there and think, well, the solution in healthcare is to put technology in the middle as a barrier. And you go, well, how? How is that even remotely okay, or even in a sentence where we say it's a solution? It's not a solution, it's nonsense. That's just my view on it. I'm like, Brad, this could get me all worked up, because
Wait,
I
I
just
feel like we need to
understood
be in a
it.
real room, because this could really get, the energy could just really crescendo. Yeah, so I definitely I'm on board with all of the inabilities of AI to do anything but remove humanity more than it already has been removed. And I would love to maybe round out with everybody's thoughts on what some improvements could look like. I'll tell you, I've had a lot of conversations with some really amazing people lately about what they're doing to work on these things, and some things that stand out. On the AI side, I'm with you. I think it's terrifying. The only thing that I've heard so far that sounds like it might be helpful is AI helping as a scribe. So the tech issue with the physician in a room and not being able to look at the patient, fine. If you want AI to do like it does on Zoom and transcribe and like in real time and make that physician not have to stare at a computer, fine. But like none of the humanistic part can be replaced by that. And second, a great idea I heard recently from Dr. Paul Dechant was literally blocking out times for the C-suite to go shadow the physicians, like to go for 2 hours, go literally into the rooms with these physicians and see what's happening and see their workflow and how unsustainable it is. And then come back and tell me that you're good with that and that you think that this can continue the way it is and that you're not going to have insane turnover. So there are some good ideas out there that are in practice that I'm loving. I would love to hear all of your ideas.
I can start. I feel like, the physicians that are in it to really help people, and the ones that aren't. And I think that, training our new crop of physicians and other providers really needs to be rooted in, real human care. And if people don't have that in them, then they're going into it for the wrong reason.
I'll bring it back to nomenclature and talk about what it means to be an advocate, and more importantly, because that word is just overused, it was already in play when we all started doing this stuff, because it really does describe what we do, but then the hospitals took it over and they have their patient advocates, and really we all know what a hospital patient advocate's job is, to put out fires and make sure bills get paid, and things don't get elevated up to that level. They report to risk management, so that is why I've been so focused on that one word of independent preceding patient advocate. So an independent patient advocate, I think it's really the only way, or at least the best way, to tackle all of these issues at the same time. I mean, we're talking about improving outcomes. We're talking about reducing error. We're talking about improving communication. we're facilitating, we are relieving the burden and stress. We are speaking for a patient who can't speak. I don't mean that in the sense of like, hold on, I got this, I'm going to speak for you. No, as an advocate, you know, you meet with your advocate. The advocate will go with you to the doctor's office, and you've got more time in the waiting room with the advocate than you're ever going to have in the actual exam room with the physician. So, you know, a skilled advocate can help decipher, digest, and convey. I'm just going to bring this back to, you know, unfortunately, I'm an idiot. I don't always practice what I preach. And I didn't when I went to my annual physical a month ago. I didn't practice what I preached. I didn't write down everything I wanted to say to the physician. And I just found myself a week later having to call my doctor after the labs came in, you know, thank God everything was all right, or we're tweaking this, or, you know, adjusting this. But it was like, what happens when you become a patient? I did what I tell everybody not to do. And I did exactly what everybody does, which is you're in the room with the doctor, and the doctor tells you, like, okay, cool. You got that? Yeah, I got it. All right, great. And then you walk out of that doctor's office, and for me, I'm like, phew, I got another year, you know? And that's it. And that's me, a guy who runs an independent patient advocacy organization. So hard. But I do believe that as the independent advocacy profession begins to expand, and it is, I'm seeing it. I wouldn't be as, like, you know, optimistic as I am if I'm not seeing it from my end, the same way that you, Dana, are seeing it at this institution that you're affiliated with. So maybe we got to have a meeting of the minds here and combine our stuff, and then we'll both see it from a different side, and that's a story that we could that we can get out there, because that is actually the same thing that happened with again, Claudia, this is going to go back to your job application, your fake job application. I don't believe that the people who take these patient advocate jobs for pharma, based on that job description, what they say they're going to do, I don't think that the people that take the jobs go in with the bad intentions. They're lured in, they're said they're going to do this, and it really isn't until they're in that job and they're locked in and they're vested that they realize that, son of a bitch, I'm not really a patient advocate, I'm a pharma advocate. Well, that's great. Guess what? You are the independent patient advocate of the future, because you have now just witnessed all this stuff from the inside, and you have the ability to take what you've learned being a quote unquote advocate in a pharmaceutical environment to actually take those skills and use them to be an independent patient advocate for individuals. So that's where I see this happening. I mean, these words are so confusing. They suck. That's the problem. Everybody wants, I mean, you ever hear of an advocate that's like, oh, that's bad. No, advocates are good. Advocates fight for people. You know, I'm going to call myself an advocate. Well, let's focus in on what we are. We are independent patient advocates. And I think that is critical, because we're never going to get away from this word advocate. You know, we're never going to lose the word navigator. They're embedded. They're stuck. We just need to distinguish ourselves from the rest of the pack.
I'm addicted to his energy. Like, I was literally just gone for a minute.
Hilarious. I know. See, I feel like so far I get like somewhat of an A for curation of amazing souls. Let's round this out. We're literally like 1 minute away, and I feel like we have to round it out with your amazing accent and insights, Olivia.
What do you want me to say?
It literally doesn't even. I feel like you need to sing an Adele song or something. I don't know. I'm kidding.
Do you know what I would like to just put in, because it was something I said at the start about how we can try and kind of meld the gap, I guess, between the patients and the clinicians, not even just the physicians, because I think that both sides want this to be better. They want the same outcome, and they're both in it for the same things. You know, clinicians don't go in it just for fun. They don't sacrifice their 24-hour days and their family and their social lives because they think, oh, this is great. They do it because they really want to help these people. And these people in that time of need really want these clinicians to be at their best and to really help them. I think we need to try and make it so that you're not on different sides, you know. You two are on the same side here. So if you two can for a second, and I know you want to, but if you two can see it from each other's side, that your physician may be taking a little while, but that's probably because he's got 40 other patients. It's not because he doesn't care about you. He is coming back. He's doing his best. It's probably his daughter's birthday and he's here instead. Okay, he's trying his best and he's here. But then on the other side, physicians and nurses and all these people need to understand why a patient is sometimes really agitated. They're scared, they're frustrated, they're hungry, they're tired, they don't know what's happening, they're lashing out for all different reasons, and they're just going through something really vulnerable for them at that moment. Can they understand the patient isn't being horrible because they're horrible people? They're not being unreasonable because they're unreasonable people. It's because they're going through something really, really intense right now. Can we try for a second for both sides to take a breath and just for a second understand what the other one may be going through, just for that moment? And I know both sides don't have time, but it's the only way, because if both sides can then fight everyone else together, fight the C-suites, fight the governments, fight the departments, fight the insurance together, well, they are then the majority. But if you've got patients angry at clinicians and clinicians angry at patients and both angry at C-suite and everyone's just bitter and angry, nobody's a majority anymore. Everyone's just angry and all have a different story. So can we, for once, just come together, sit on the same side of the table and say, we want better healthcare, we want better outcomes. Let's work together now. Work together to make this sustainable now and into the future. And just leave it there and then fight together, but actually be strategic together. And I see what you say, Brad, with the advocate thing. It's a bit of a buzzword, the same as AI. Like, oh, who isn't an advocate? Physicians say, well, I'm an advocate too. And patients go, well, I'm an advocate. And then there are real advocates. It's tough because the word should actually mean something so much more powerful, which is we have to be here because there's a really big problem. And that's what needs to be addressed in. And the navigator word and all this nonsense, it doesn't mean anything anymore. And I think the word advocate needs to really mean something. And what it stands for is there's a problem. And the problem is so big that these people need defending. And they shouldn't need to. Healthcare shouldn't need defenders. It shouldn't require protectors for people to just have a life. So that's kind of my finishing up piece on this. Let's just unite together and make this better.
Emmy award winning. I mean, there's nothing left for me to say. You all are fantastic.
Let's make it a plaque.
I just have to say, I think an advocate really is a surrogate or a proxy for an empowered and educated patient. But when you're in that vulnerable space, you might not have the time to be that educated and empowered patient. So
yes,
100%. I'm going to end it on this and just say it's up to the patients and loved ones too. And they're the ones we need to educate because when you're the patient, like you just said, you're powerless, you freeze.
Yeah. Well, a lot of the time they don't even have the energy to be thinking about this. They just want to get home because they're tired and they're going through a lot. It's just like, I don't care. Let me just go home.
So
thank you all for this amazing conversation. Great. I love it. I'm already excited for the next one. This should be live and it may not have been. If it's not, the recording will be up soon and I will share, but I really appreciate you all taking the time out to share your insights. And I hope that those who hopefully watched it live found this engaging and valuable and worthy of their time. So I appreciate you all.
Thank you all.
And thanks
for bringing us together.